healthcare is shifting, but is it shifting in the right direction? Value-based care is designed to improve patient outcomes while controlling costs. But who's really benefiting? Today, we're exploring the impact of value-based care on patients, providers, and the healthcare industry as a whole. Just a small ask. What's working, what still needs improvement, and what lessons have we learned so far? Stay with us. You won't want to miss this conversation. Okay, so today's topic is a bit of a daunting one for many, but we're going to do our best to cover what we can in this one episode, knowing that we're definitely not going to get to it all, and there's a lot more resources available, but it's value-based care. So in short, value-based care incentivizes providers to provide better quality care while reducing costs, so they get paid for that quality that they're delivering. Let's start with just a state of play right now at how we're seeing value-based care happening currently in the care at home community.
Yeah, Elyssa, this term value-based care, it's sort of a buzzword, right? You can't go to a healthcare conference without a panel discussion on value-based care, and it's sort of the term that's defining, and for many ways, for the right reasons, right? It's about the relationship between quality and outcomes and cost. And our healthcare system is pretty expensive. It's costing, if we're looking at the Medicare, Medicaid system, it's expensive government, part of the government budget and state budgets. And so it's serious business. I have to say, I don't love the term anymore. We got to come up with something else. I don't know if we'll get it on this show, but eventually, for whatever reason, value, and I think I've seen some patient in public surveys on this, like when they hear value, what they're thinking of is like the side menu at Wendy's, or like what
Maybe
you
the
can
exact
get,
opposite of
like
what we need.
the special rack, like at TJ Maxx, where you can get
I like that kind of value.
I like it too, but I don't know if that's how people want to think about like the future of their healthcare system. Kind of scrounging through the value rack, if you know what I mean. So this is a big topic, like you said. It touches on if we just take it from a care at home perspective. So much of care at home is around elder care and aging, as well as disabled care. So we're really talking about what's happening in value-based care in Medicare and in Medicaid, because those are the programs that are largely financing healthcare for older and disabled people. And there's a lot to talk about. So, we could dive into Medicare Advantage, the private Medicare plans. That is its own sort of value-based construct. And there's a lot of interesting things happening within Medicare Advantage, a lot of growth in Medicare Advantage. And then within the traditional Medicare program, we have a number of initiatives, demonstration programs, and other activities orienting towards value. But I want to say one last thing about this that I think I always think about. So it's great. We're going to align payments with value. We're going to pay providers to do good care and get good outcomes, and that's how they're going to win. And I sometimes think about my dad. Okay, my dad is a retired family dentist, and when he was in his practice, I remember as a kid watching him, and he would, sometimes, have a very slow morning at the office, not see a lot of patients, not bill for a lot of care, because he had some older patients that he would actually go himself to their home, pick them up, even though they had the walker and the slow mobility, make sure they got to the office, got the care that they needed, and that was good care. And that was done because of professionalism and a commitment to doing good work. And there was no special program. The insurer didn't need to give him a quality bonus, for doing that type of thing. He did it based out of a sense of professionalism and commitment to patients and the sort of the professional ethic. So I think that as we talk about value-based care, we should be excited about the opportunities that it creates for better care. But we should also remember that healthcare professionals, healthcare institutions, and providers also can do good work really in any type of payment system if their ethos, their training, their orientation is right.
Yeah, that's a great point, and I think we've seen that to date so far in the care at home community. Let's focus in on home health demonstrations and models and value based systems that we've seen. I know PACE, program of all inclusive care for the elderly. I know there have been a few other programs. Is there anything you want to specifically touch on, models, demonstrations, or value based systems that we've seen work or not work?
Yeah, Alyssa, I think that the take home point that I've seen with all these different demonstrations, and I want to just say I've personally been involved in a lot of these as a leader when I was working as a CEO and physician leader on the provider side. Got involved with the Independence at Home demonstration, the community based care transitions demonstration, the primary care first demonstration, the bundled payment for care improvement
And the list
demonstration,
goes on
the
and on.
comprehensive care for joint replacement demonstration, the ACO REACH demonstration, and integrated care for kids demonstration. And so I've gotten invested in some of these different activities. I forgot about Medicare Choices model, which we talk about in another episode. So there's one thing that I think all these models that have had in common when they work. Okay, when they work, they are about helping people stay healthy at home. They're about getting people home from the hospital faster, and safer, with better outcomes, with better cost trajectories. So
Yeah.
here's the big thing that everyone, when we're thinking about value-based care in the Medicare program, largely what we're talking about is enhanced care at home. We're talking about, because it's such a cost differential. We're talking about, thousands and thousands of dollars for institutional care, or for an unnecessary hospitalization, or an unnecessary emergency room visit. And when we support people at care at home with some nursing visits and some telehealth and telephonic support, physician oversight, whatever it may be, it's so much more cost effective. Those things don't cost tens of thousands of dollars. Better end of life care, more proactive when it fits the person's clinical situation and goals. Hospice care. That's really the stuff that drives value. And so lots of opportunities in there. There are things that have worked and haven't worked across those different models. I think one of the things that I don't know if they were skeptical, but I worry about a lot in most of the value-based models. Really all of them, including what happens in Medicare Advantage, is that if you're going to pay people for outcomes, you have to have a way of measuring those outcomes. Things like hospitalizations, emergency room visits, those are relatively straightforward to measure within the claim system. But what about quality, patient satisfaction, improvement in function? It's not just measuring quality in these models that's important. There has to be some risk adjustment, right, for these outcomes, because one person who's very, very high risk might have a bad outcome, like a hospitalization, but that might have been unavoidable just given how high risk they were. And somebody that's low risk might have a hospitalization, and that's really an example of pretty bad care. Like, why did that happen? That person was so low risk for something. So you have to have a way to measure quality, and you have to have a way to risk adjust in these models. And what that ends up happening is that providers, and if we're talking about the Medicare Advantage plans, they get really focused on coding. Okay, they basically, it becomes an entire competency for the organization, is to make sure that you're coding well enough so that you don't get basically disadvantaged in the in the risk adjustment systems or in the quality score systems. And sometimes I wonder, is that taking the focus away from patient care? Like that example I gave about my dad, doing what he could to provide a great experience for somebody. He wasn't worried, did he check 7 boxes on the person's, coding to make sure that he got credit for doing good care. He just did it.
If you're looking at what's been done so far, are there any quality indicators that stand out to you as having worked, or just generally speaking, any lessons that you learned from creating new care structures, if it was a new staffing structure or a new quality indicator internally that you were tracking, that enabled you to have success when participating in some of those models and demonstrations?
Yeah, I mean, I think that one of the critical things is risk assessment and triage across the board. So You need to know who's at high risk, not just who are the high risk patients, but also what are the high risk moments in a person's care journey. So things that, tools, analytics tools that kind of help you triage who needs help, and then having a team set up for rapid response. Okay. A lot of times we're talking about the most critical issue in these models. Again, they're about quality improvement, but a lot of it is about lowering unnecessary hospitalization. So you need to know who's at risk. And the risk tools, and then once you know that people are who's at risk, you need to be able to respond to it and have a team. So that might mean having on-call services, telehealth tools that you didn't previously use to triage more urgent situations quickly. I think when we're talking about value-based and risk-based care in frail elders with serious medical problems, if we're not also putting in place palliative and end-of-life care competencies, we're likely to miss the boat as well. Because if those issues go unaddressed, a person's going to keep, they're going to keep going back and forth to the hospital, back and forth to the hospital. If they have essentially an uncurable condition and the goals of care and the care plan doesn't match what they have. And so in those situations, those are some of the tools that have led to success in those models.
Yeah, that's interesting. I hear you talk a lot about technology, telehealth, which of course we know we're already using a lot of here now, data analytics, potentially creating dashboards to track patient outcomes, knowing what those key performance indicators are for success in that model and tracking those. Of course, you measure what matters. That helps you see success. You talked earlier about communication. What role does communication play in this? So if you're creating, in certain instances, relationships with other systems, healthcare systems, plans, things like that, how do you communicate your value to that partner so that you can create that relationship and deliver on the value that you know you can provide?
Yeah, I think everyone in the care at home world does have some special powers in this whole value-based paradigm. Okay, because we're experts at helping high-risk, seriously ill people stay healthy at home. Home health agencies, home-based care organizations go to potential partners in their community, in their system, making sure that they can use those superpowers in that partnership is really important. And because the hospitals and health systems, they're not. It's been a decade, but one of my colleagues that I work with at Cleveland Clinic, somebody pretty high up, said to me, Steve, it's great you guys are working on this home care stuff, because we still haven't figured out what to do when the patient leaves the operating room, let alone when they leave the hospital. So there's some growing expertise around community-based care in our hospitals and health systems, but it is not like what the care at home community has.
Right.
And we've got to make sure that we're in those conversations.
You've made it really clear how high the stakes are. So it seems like a really great call to action for everyone listening to make sure that you're involved and have a seat at the table when we're fighting for these policies that support the type of care that we can deliver best. So come, join the Alliance, get involved, become an advocate. I think you can get involved at allianceforcareathome.org/advocacy. You can become a grassroots advocate, and you yourself can be communicating to your lawmakers what's important to you and what we know will best serve the patients and families at the end of the day. And then, of course, staying up to date and keeping ahead of whatever models and demonstrations or whatever's coming our way next. That's another big piece of what the Alliance helps with. So if you sign up for our newsletters and join our community, you'll be prepared from a regulatory compliance and policy standpoint to meet the challenges that lay ahead.
Elyssa, that's right. The Alliance is here. We're not just about yesterday's care at home. We are focused on helping
shaping the future.
That's exactly right. We're helping our members navigate these opportunities and risks, quite frankly, of the future. We have members that are leaders in some really fascinating models. This ACO REACH model for high needs beneficiaries. We're seeing some of our members work like in a home-based primary care model where they're actually bringing the physician and advanced practice nurse care for ongoing primary care into the home, and working with home health and hospice and in the right situations and really provide ongoing medical care at home. And that seems really promising. A number of our members are what we call pay-viders. They've sort of forayed into Medicare Advantage special needs plans, which are sort of different than the general plans. These might be for dual eligible beneficiaries that are both Medicare, Medicaid, or for institutionally eligible beneficiaries. These are people that would meet criteria to be in an institution but are getting cared for at home. So these special needs plans are really interesting. And our members actually have a lot to teach one another about their experiences in some of these models. And we're definitely shaping the future, and we're not afraid when we talk about a model maybe having flaws. We're not going to, just because something's new or it's sort of has some innovation to it, if it's not patient friendly, if it's not supporting patient-centered care and families in the workforce, we're gonna talk about it. We're gonna tell the truth and not just get excited about every shiny coin we see on the ground, but we're also looking ahead and looking forward.
This show is brought to you by the National Alliance for Care at Home, because every person deserves access to high-quality care where they feel safest, at home. The Alliance is working to advance policies, support care at home professionals, and shape the future of home-based care. Visit allianceforcareathome.org to learn how we're driving change and you can get involved. All right, let's go back to the show.
For our next segment in this episode, we are thrilled to bring in an expert in value-based care with a diverse background in healthcare leadership that spans from providers to plans. Jennifer Veneri, Vice President of Population Health and President of UPMC At-Home Services. Under Jennifer's leadership the last 9 years, UPMC has embraced innovation and streamlined clinical operations through clear strategy, business process improvement, and new program development initiatives that have significantly enhanced service and care delivery. Jennifer, welcome to the show. We are so excited to learn with you today.
Thank you for having me.
So let's jump in with a little bit more about your story. What led you from your role leading UPMC to your current position with the health plan?
Sure. So I'm honored to step into the role of VP of Population Health at the health plan here at UPMC. In this role, I'm helping to advance UPMC's vision on how we improve health in our communities that we serve, and just work across divisions as a payer and a provider to ensure that we're connected and we're as patient-centered as possible. And in the spirit of what defines UPMC, just collaborating and innovating.
Thank you for that. Let's now zoom out and think about the sector as a whole. This is no small question, but as you would define it, what is value-based care? We hear this term all the time. We probably use it ourselves, maybe without a full understanding of what we're really talking about.
Sure. So I think to start with is maybe I'm going to go towards the conversation of misconception with value-based care and what people think it is or it isn't. I think a really big misconception for value-based care is, if we think back just a few years ago, maybe 10 to 15 years ago, your doctor held all of your information for you, right? And people weren't as engaged in their healthcare. You fast forward to current state, and even just a few short years ago, you can pretty much Google anything. So this was very close to me. Last weekend, I actually had a friend that reached out to me, an older friend, and he said that he wanted to go to the doctors to get his diabetes checked, was what the information was he was giving me. So he decided that he was going to eat healthy, in his words, for about 24 to 48 hours prior to this visit with his physician. And when he got to the appointment, he realized that he had his blood work drawn beforehand. His physician was ready to go over his A1Cs with him. And this gentleman did not understand that A1C is your glucose readings over a period of time. So after all of this was explained to him, he realized that all of this information was at his fingertips on his phone, and how the information was actually communicated with him prior to even the doctor having the information. So that brings me back to your question about being engaged and what the misconception is in value-based care in general. Having the platform for patients to be able to be lock and step with their provider and to manage your care yourself with your provider so you're next to them is something that I don't think a long time ago existed. And I would like to think of that, and I explain it a lot of times as that essentially is we can value-based care. It's the value of being and engaged in your care up front with your physician, and you're part of the outcome. So connection, education, and involvement between everybody and the physician.
Thank you for painting that picture. And it feels like, that's a really great blue sky to be working towards. So in reality, what are some of those success stories of how this model is working that you can point to when everything goes the way we want it to?
So that's a big question too, right? Whenever we talk about value-based care and which direction we can go, I think a lot of people think that value-based care is just essentially when you're sitting on the provider side, it appears as if it's more transactional. And value-based care in general, we should look at it as whole package care delivery. What we're doing from part one, the whole how we provide excellent care, the experience during that excellent care, and then the outcome of that excellent care, and having high quality, high value healthcare.
So practically speaking, how would we measure that? How do data and analytics play a role in measuring and achieving the outcomes that you're looking for?
So I always say data analytics drives change, but it shouldn't drive care delivery. Essentially, we know as providers the care that we need to be delivering, but there are table stakes such as access to care, understanding and dissecting data really puts you in a perfect and the prime place to say, what is the true cost of this care? What are the behaviors related to this? And then what are the utilization trends?
Dr. Landers, I'm curious for your perspective when you think about some of the things that we could be measuring or the role that outcomes can play in helping providers shape what they're measuring. What comes to mind for you?
Yeah, I think it's been a positive thing in healthcare, I think, to move to more outcome, oriented constructs where, whether it's the plans or the providers, that we're more and more, being held to some types of outcomes. I think, as a geriatric medicine professional from the background, I definitely would love to see things that were, more and more relevant for frail elders, so as people get, older and lower mobility and maybe have multiple conditions, some of these single disease or condition measures aren't as relevant anymore. It's really more about things around quality of life or function or falls prevention or goals of care conversations or family caregiver burden and things of those sorts. So I definitely want to see more, improvement and, for special populations and highly vulnerable populations and making sure we're measuring the right things. But the overall trend is very positive.
And do either of you have any practical advice for providers around making the most of their data? I know there's a lot of new technology that's been introduced in the last handful of years, and we see that trajectory kind of continuing to skyrocket up. It can be a lot to digest and to figure out where to go first. So yeah, any advice you would think about for leaders on the ground?
So the advice that I would give for providers and leaders on the ground is risk stratification is so very important. And whenever possible, use your EMR data or your EHR data. Use analytics when necessary. And applying a risk stratification allows for panel management and allows that provider to take a true deeper dive into the information. And then it's not always about the patients that you see all the time, right? The patients that come into the office, that get their annual wellness visits. It's more so about the patients that are, for lack of better words, hiding. The patients that don't come in on an annualized basis and making sure that, you look at that risk stratification through your panel management. And then I think that allows the provider to have a 10,000-foot view of whole patient care.
You alluded to this a little bit in that answer. And so when talking about the patients that you don't necessarily have as much of a high touch relationship with, but I know there are lots of other challenges facing our community right now. So given the current state of play for our sector, what challenges do you see in the short term or immediate future for providers?
So short term and immediate challenge or opportunity, I would say, is staffing, and that's just at a national level across the board. I can tell you that staffing has somewhat leveled off here at University of Pittsburgh Medical Center, and we've truly become the employer of choice in the area. People want to work with us. This has come out post-COVID. So some of our staffing challenges, not all of them, but a lot of them have resolved. We've worked closely with our schools of nursing, and we've created a lot of pipelines in the community that has served us well in this arena. A challenge for tomorrow, I would say, is definitely reimbursement models, right? The uncertainty, new legislation that impacts the Medicaid reimbursement is something top of mind for all of us. So we just continue to stay focused on what matters most, which is our patients and our people.
Absolutely. Dr. Landers, anything to add on either of those challenges? I know reimbursement and workforce are probably the song and dance that we sing and dance every single episode that we have, because it's just so pertinent across our community and really impacting the delivery of care.
Yeah, I mean the core, all of our care at home providers, they're really focused on people. They're really just people caring for people, and you've got to have the you have to have the talent in order to be able to serve. Especially people that have special needs that require special training and experience to do a good job with. Certainly, we know if we're talking about like post-acute care, for example, a lot of that is a weekend business. The hospitals tend to move their discharges late in the week, and if we're going to get out and see them quickly, it's a Saturday or Sunday type of operation. And in order to resource that, having those really skilled, talented people available on the weekends, you've got to have a strong workforce. And one of the things I like to say is that reimbursement policy is workforce policy. The purchasing power that the agency has to be able to address those challenges is tied to the reimbursement dynamics. And so that's important. I think there's always been a hope. I think that with value-based models, that somehow there would be enough downstream savings, enough really changing the cost trajectory to really create the momentum for investments in that type of high level talent pool, targeted. I liked what Jennifer said about targeting, because I think that that's critical, because so much of what we do in healthcare is really, really high value when it's done in the right place in the right time, and so much of it can be low value when it's deployed when it's not needed, or it's not necessary. And so I think that's critical. But I'd say overall, personally, if I look at the big picture, I'm not so satisfied that we've gotten this balance right across the board. I think that that there's something missing, because when I go through, talk to kind of your providers and care at home community members and home health agencies, it just seems like they're struggling more than they should be to be able to succeed in this value-based environment. So we've got to keep having better conversations.
That's the perfect segue to an opportunity for those conversations. So with policymakers and industry leaders listening in potentially, what do we need to do next to help protect high quality patient care? Where should we be focusing our attention first?
So I can speak specifically at UPMC. Of course, we work closely with government relations, who are the experts for us with our locally elected officials, making sure that our local legislators are informed of all angles of a proposed bill or legislation. And then, of course, always considering and taking into consideration that every community is extremely unique when it comes to providers and healthcare delivery. And then UPMC is one of the largest employers in the area here in Pittsburgh and beyond in the state of Pennsylvania. So it's just important for us to make sure that our voices are heard and that we're continually improving the health of our population and the well-being of our communities.
Yeah, Jennifer, I mean, UPMC just has such an incredible reach and reputation for excellence. And, we're proud to get to talk to you as a leader and a leading organization on these topics.
Absolutely. And from your 30,000-foot view that you have leading such a large health system, like what do you think about in the next 5 to 10 years with the trajectory that care at home is currently on? And again, with your perspective from leading at UPMC, what excites you the most? What worries you? What are you thinking about in that longer term horizon?
Sure. So that's a great question. What excites me the most is probably being in a position here at UPMC that allows me to reach across the table and hold hands with the provider side, the payer side, and just really set the system up for success as we move forward. Utilizing analytics and data to predict and design models to meet our patients where they are while we care for them in the most unique place in their home, which is where I always say care matters the most, when you're delivering it in somebody's home. And then optimizing care, of course, across all sectors of the healthcare continuum, and never forgetting about pharmacy and DME and all of those extras that come along with providing care at home.
Thank you. I just have to ask, I know this is not what we plan to talk about, but being that you're in Pittsburgh, do you have thoughts on the Pit?
I do have thoughts on the show The Pit. Yes. So it's a little more realistic than some of the other shows I've seen. I can tell you that that the landscape is great, right? It definitely embraces the landscape of Pittsburgh, but they probably have done a better job on that show than I've seen in the old school, like ER and those other shows. So I'm a fan.
That's what I've been hearing too. So I just had to get your take, boots on the ground.
I think I'm missing out.
Yeah, you're gonna have to tune into that one.
Okay, anything else you want to leave listeners with today? I think there's a lot of good nuggets. We could spend a whole nother episode unpacking, but value-based care can be an enigma for some. So last takeaways?
One other thing I wanted to just check on, because I remember from one of our conversations that there was some community-based clinical programming that you were proud of that was really helping people stay healthy in the community. And Jennifer, if you could just touch base on some of those programs, I just think people would be interested to hear about it.
Sure. So we started last May. So it's been a little over a year. We started a specific Medicare program for UPMC health plan members that is in Pittsburgh primarily, and it's called UPMC Your Care. And that program focuses on our most vulnerable population, along with, putting my plan hat on, our highest utilizers. And we have pretty much every discipline included in that service line. So we have nurses, we have physicians, we have paramedics, we have community health workers, social workers, a triage team. And these people go out into the home. We meet people where it matters most, right? In their own home. And we deliver care in such a fashion that we try to deliver what we can in their walls so that they do not have to go to the emergency department. We do everything from IVs to telemedicine to setting up the UPMC app on their phone so that they have care at their fingertips. And then we do med reconciliation, anything you can think of.
And is it working?
It's working beautifully. Yes. Very proud of that team, very proud of that program. We are looking to expand. We're just making sure that we have enough information over the past year to look at data and to really show that we're making it happen on what we're doing.
That's incredible. Glad to hear about it. Sorry I diverted us, but I wanted to hear about that.
All good. We have a great team there, so it's exciting stuff.
Thanks for jumping in with that question. I think that's another good thing for providers to think about. What other models can they be implementing even ahead of any changes that they'll be forced to make? Like, how can we be proactive and getting ahead in value-based care? So thank you again for your time today. It was a pleasure to have this conversation, and we'll have to have you back on again soon.
I would love to. Thanks for having me. I appreciate it.
If you made it this far, clearly you care about home care just as much as we do. Do us a quick favor, subscribe, leave a review, and let us know what you think. Got a hot take on value-based care? We're all ears. Just search for Who Cares or the National Alliance for Care at Home, tap that subscribe button, and you'll get new episodes, insights, and the latest on how we can reshape care at home together. Healthcare is evolving, and value-based care is reshaping how we deliver and receive it. Thanks for joining us, and remember, care at home will impact us all. Let's shape the future together.